You mentioned, we talked a little bit about imaging, and you mentioned CT angiography is, angiography being one of the gold standards, contrast angiography, which, this invasive. There's some people that don't need it. They're not, particularly if they're not symptomatic or there's not some other high risk event going on or process. So a lot of people are taking comfort in the coronary artery calcium scan. Like I mentioned, I had one; it was a 0 score. How the critics of that will say, well, it's missing all this soft plaque, and a 0 score is meaningless. I would say that it probably isn't meaningless, and it probably predicts less soft plaque than having a positive CAC score. But what do you think about? There was a study out of, I think we mentioned this. I think it was Denmark, I believe, where they looked at zero Cac scores in symptomatic people and LDLs up to 190 plus, no increase in MACE type things, but there was a trend towards higher plaque deposition over 190. What are your thoughts on relying on the CAC score?
So that's getting a lot of attention in the guidelines. So Cac scoring has a lot of advantages. One advantage is that it's very standardized, it's very easy, it's very inexpensive. People can usually get it for $100 or less. And a Cac score, at least in the MESA study, Framingham, and other large data sets, is very predictive of 5 or 10-year cardiac event rates. So if you have a 0 coronary calcium, your 5-year event rate is very low. In many cases, your 10-year event rate is very low. So from the purpose of saying, am I at increased risk for an event, a 0 calcium score is very reassuring. So that's true. On the other hand, a 0 calcium score does not rule out the presence of plaque. And CTA studies, which is a virtual angiogram, computed tomography angiogram, has the ability to find plaque, which is soft plaque, not calcified. A good number of individuals with a 0 coronary calcium have plaque identified by CTA. So on the one hand, there is plaque there. On the other hand, a 0 calcium score is predictive of fewer events over a shorter period of time. Now, that can be very helpful for people who are older, right? So let's say 60, 70-year-old, 10 years is a very meaningful time frame. What about a 40-year-old? Well, a 40-year-old, 10 years gets me to 50. It doesn't get me to 60, 70, or 80. And there is the shelf life for the limitation of Cac scoring, because Cac scoring is less helpful for younger people, more helpful for older people. A 0 coronary calcium doesn't mean I have no plaque, as you said. There can be soft plaque there. But as I get into my 50s, 60s, and above, a 0 takes on increased significance of decreasing my risk. The guidelines actually talk about de-risking people, which I think is a very interesting concept. And I like it because, if you think about it, you have to be able to be healthy and older. That has to be possible, right? You have to be able to be a 60, 70, 80-year-old pretty healthy person. And if that's not true, then all of this is a house of cards. And the self-fulfilling prophecy is it's just a matter of how bad you are and you can never be good. So what does good look like? Well, insulin sensitive people, that's great. Good blood pressure, good diet, exercise, 0 coronary calcium. This is all very reassuring, right? And should we be giving medications to people just because their LDL is less than optimal? I think Cac scoring is one of the things that helps us have a better conversation about that. This is what we do with the testing that we developed at Precision Health Reports. I mean, the question is, what's the totality of the person? What's your insulin resistance look like? What's your metabolic syndrome severity look like? What is your diabetic risk? What's the status of your vessels? And now we put all of that in context. Oh, and I happen to have an LDL cholesterol and an ApoB. So what happens if I have an ApoB, which is not favorable, but I have a 0 coronary calcium? I think you're in a good place to have therapeutic lifestyle change and continue to monitor. I don't think those people have to be on the statin, right? Because we have no evidence of disease by Cac. We have otherwise good physiological parameters. We've got an ApoB, which is not great, but something that can be watched and monitored, right? Now, that's a general statement. There are extremes of ApoB that I would feel uncomfortable leaving alone. If you give me an ApoB that's over 160, that's like the 98th percentile, I wouldn't leave those people alone. But more commonly, we're talking about people whose ApoB is 120 to 130. Their LDL cholesterol is 130 to 160. Not great numbers. Do I medicate those people? No. The first thing is I want to work them up and see if there are underlying root causes I can affect. I want to try to optimize therapeutic lifestyle. I want to look at their imaging studies on their vessels. And the last thing is, according to the guidelines, we need to think very broadly about what are called risk-enhancing factors. There are over 40 risk-enhancing factors that contribute to vascular risk and have nothing to do with the calculation of 10-year and lifetime risk by the pooled cohort equation, don't have anything to do directly with other major risk factors. We're talking about things, for example, like psoriasis, rheumatoid arthritis, inflammatory disease. In females, preeclampsia, premature menopause, individuals who have other comorbidities that increase their risk. So if we're going to actually have a shared decision-making conversation per the guidelines, what we're supposed to do is take a comprehensive clinical history, add to that biomarkers, add to that risk-enhancing factors, consider imaging, integrate the 6 different U.S. and international guidelines that speak to cardiometabolic risk, and put all of that together for one patient at a time to have this better conversation than just what's your LDL. And that's what we put together at Precision Health Report. It's a very simple method whereby people can answer a few questions online, get their blood work done, and then a report is generated that tells them all of these things so that they can have a better quality conversation like we're having today, not just, looks like you have no major risk factors, but your LDL is high. What should I do about that? I'll give you a statin because it's easy.
Yeah, that seems to be kind of lazy medicine, and I get it. I mean, many physicians, they've got 15 minutes, and it's just not enough time to really do the justice that needs to be done. And I think, like I said, I don't know why some people's LDL cholesterol goes really high, and I've never said ignore it, but I do think it's very nuanced, and you have to get in. Why don't we just measure? I mean, why isn't the standard to measure ApoB now instead of the standard lipid panel? Total HDL, calculated LDL, and triglycerides seems to be, I don't know, is it cost effective? Is it that helpful? Is it less helpful than it used to be? Why don't we just go into ApoB directly?
Well, I have opinions about this, but again, I've spent 30 years seeking to understand the difference between measuring a particle number versus just measuring the cholesterol in a particle. And I can say I've lived long enough that many, but not all guidelines agree that ApoB is a better measure. It's more actionable. It's a better reflection of response to therapeutic lifestyle or medication. It is also, in a recent JAMA Cardiology, very large population, UK Biobank, plus the Fourier study, plus other studies, nearly 500,000 individuals. The only significant predictor in primary or secondary prevention of events was ApoB. It was not LDL cholesterol. It was not non-HDL cholesterol. The Europeans promote ApoB as a target of therapy. The Canadians promote it as a target of therapy. In the US, some guidelines give it as a secondary target of therapy, but it's not given as a target of therapy in the ACC-AHA guidelines. Part of that is cost. People say, well, it's going to cost extra money, therefore I'm not sure if the cost is worth it. But what is not in question is the following statement. If ApoB and cholesterol values disagree, they are discordant, risk always tracks with particle number. There is never an exception to that statement.
Yes.
Therefore, why on earth would I make LDL cholesterol my final answer when I know that it is not a good predictor of individual risk and ApoB is much better?